Good afternoon to everyone. I hope all of you are comfortably settled at home or in your office or in the clinic. So we have chosen the topic for today to be managing joint pain in primary care, the new normal. And certainly this is relevant in the current environment with COVID. So we wanted to share with you how we can go about treating joint pain problems in patients in this current environment. The disclaimer slide from Pfizer just says that this talk is for doctors and do use any of their medications according to their prescribed instruction sheets. So we like to call this the new normal because I feel that tele-consult may be something here to stay going forward for the next couple of years. So in addition to actual physical consult, I think doctors may have to build in tele into their services. The differences with tele certainly, of course, is that you don't see the patient in person. There's no physical interaction between you and the patient. So whatever history, whatever diagnosis must take place across the screen. And this presents a very different sort of diagnostic pathway. If you can see the top row, this is the traditional pathway from history to examination to imaging and then diagnosis. In tele, you have to take a history and you can do a visual examination and you move on straight to your diagnosis, or sometimes provisional diagnosis if you're not able to come up with a confirmed diagnosis. So these are the limitations of tele. Also, I'd like to add on that there's a whole other aspect of tele, which is ethical concerns or ethical limitations, where you should make known to your patients the limitations of your diagnosis if you find that you're not able to come up with a proper one. Let's start with the different types of joint pain which doctors in primary practice may face. And this is, in general, how I like to categorize them. On the left, you have injury or exercise-related type of pain. In the middle is degenerative, so mainly your osteoarthritis. Now, I put all the rest into one big group. So the rest includes reactive, for example, due to viral fever, acute flare-up, loose bodies, rheumatological, for example, rheumatoid arthritis. And we should never forget that there are always more pathological causes, for example, like septic and tumor-related. As orthopedic surgeons, these are probably the two most disturbing conditions that we want to make sure that they are not. Let's take a look at each of these categories. So for patients with injury or exercise-related pain, it should be quite clear. Patients with injury, for example, knee sprain during soccer or during basketball, that will be quite clear. Exercise-related pain is, for example, knee pain after, for example, running like 15, 20 minutes. Usually the patient finds that they are still able to continue running, but they have a bit of pain after the run, and maybe they just wanted to seek an opinion on, is it serious? Can they continue running? Now, for these kind of cases, the first thing that crosses all our minds is there a fracture, especially for acute injury? Is there a fracture? So what we can do is to inspect visually. We look at the degree of swelling, range of motion, and the ability to weight bear. So in the patients whom I've had teles with, this is actually what I ask them to do. And most of them are able to show me pretty well whether they can do these things. We will talk a bit more about this later. And so if you think it's, for example, if you think it's an ankle sprain or a minor knee sprain, you can apply RICE treatment. So this is commonly known to all of us as rest, ice, cold compress, compression, and E, elevation. For ice, this is what I tell my patients to do, to put ice cubes in a towel, and then they can do it about 5 minutes or 2 to 3 times per day. Now, to get compression, that may be a bit challenging, but we have found one way. If you have an ankle sprain, for example, you can wrap a hand towel around the ankle, and then you use cling wrap. Cling wrap, the cooking cling wrap, is a little bit elastic, and so you go around the ankle and give it a little bit of compression, a little bit of pressure. Now, at primary care, the other main group of problems that we see is degenerative. And again, this should be quite easily diagnosed. Usually, patients have progressive increase in pain and it's mechanical. The very common examples are these: knee pain when climbing stairs, heel pain after walking, so for example, plantar fasciitis or heel spur, hip pain after walking, hip osteoarthritis, shoulder pain lifting up or sleeping on the shoulder, for example, shoulder impingement, or perhaps you may think that is rotator cuff, like a tendinosis. For these cases, make sure that there are no red flags, and we're talking about the usual red flags like night pain, night fever, loss of weight, and then you can institute rest. NSAIDs are a mainstay of treatment, and we'll come to it a bit later. And simple exercises. I like to give my patients these kind of sheets for exercises. So for a patient with knee OA, minor knee OA, and a bit of pain, you can show them this. For example, you can email them this, and they can follow the instructions and do it. Now we come to the big other. We come to the big others category. So this is a category of all other causes of joint pain. The first one I put is reactive because viral illness is very common, and we do know that, or rather doctors do know that COVID-19 themselves in itself can also cause joint pains, just like any other viral illness. The other types of conditions are acute flare-up. So this is what I mean. For example, OA with exacerbation, the patient can have acute swelling. It can be acutely painful. So this OA exacerbation, gout or pseudo gout, it can present with just sudden pain, sudden swelling. And usual treatment is RICE again. And again, at the back of our minds, we are thinking, does he need aspiration? Could it be septic? Now, aspiration, usually you'll reserve it for patients with large swellings, severely limited range of motion, for example, less than 90 degrees. Septic, now this comes down to a judgment call, and again, we'll talk a bit more about this later on. Loose body. Patients with loose body may feel episodic sharp pain sometimes, and in between, there's completely no pain at all. So for these kind of cases, you may ask them to wear a simple knee guard and observe. Sometimes loose body symptoms do just disappear on their own. This is because the loose body lodges in some part of the knee and just stays there without causing problems. Certainly, if a patient is symptomatic for example, 3 or 4 weeks, then he should come down for a physical consult. Now, rheumatological type pain, rheumatoid arthritis, for example, psoriatic arthritis. Now, these are more non-mechanical pain, and maybe there's more pain at night. And as I mentioned, orthopedic surgeons, we are always wary of whether it's septic or tumor-related type of pains. So we have gone through the types of joint pains. Now, the next slide is going to show you how to distinguish between the different types of joint pain through a very simple flowchart. This is how I approach my patients. First, I take a history, and then I decide whether it's acute or progressive. I find that these group of conditions like injury, reactive, acute flare-up, loose body, septic, these have acute presentations. For progressive increase in pain, these are more, for example, exercise related, degenerative, rheumatological, or maybe tumor related. After you group it into acute or progressive, the next thing you do is visual inspection. What we want to look for are red flags and range of motion of the joint. In this case, mostly we're talking about the knee, but certainly you can apply this to the ankle, the shoulder, the elbow. After this, this is where your index of suspicion comes in, and then you try and make a diagnosis. Which of these is it? Is it safe to treat through tele, observe for a while, or should you refer to a specialist? And next slide, we will give some examples. These are some examples of certainly red flag looking kind of images. Swollen, a very fierce looking red knee. Certainly this, just by looking at it, it could be septic, it could be acute gout. You wouldn't really be able to tell. And certainly the minimum for this is that you should ask the patient to come and see you physically so that you can have a good look at it. Same for this knee. Again, this may be cellulitis, maybe gout. Such an appearance of a hand or wrist certainly is not normal. It's very swollen, skin is shiny, and a lot of erythema. So this is definitely infection. And when the patients show you, they can point to the location of the pain. Usually I like to ask them to try and point using one finger. For range of motion, view it from the side of the joint. So if you want to see the range of motion of the knee, you have to ask the patient to stand perpendicular to the camera so that you're looking at the side of the knee. And you can also get this kind of information. You can ask them to walk. You can ask them to get up from a seated position, especially for patients with back pain. You can check their shoulder movements. Does it look like it's impinged? Does it look like he cannot lift up his arm? These are all the visual cues that you can get through tele. Now, I think the most common conditions that primary care physicians may have are these. For example, this may be an ankle sprain. Certainly when we see a bruise, a bit of swelling like that, we do worry whether there's a fracture. But if the patient is able to walk around, weight bear quite well, and maybe, for example, he's able to weight bear just on one leg, you can be quite assured that there shouldn't be any major fractures. And a lot of ankle sprains do have bruising like this. It accumulates over the lateral side of the heel. And for cases like this, where the patient can lift up one arm, but it appears completely stuck on the other arm, this may be a frozen shoulder. And the other thing is back pains, back aches are probably going to be quite common with a lot of people working from home, sitting down for hours at their desk. And it's something that I've seen myself too, slight increase in back pain patients due to all the hours at their desk. So when you have come to a diagnosis, these are the general measures that you can do through tele. You can ask them to rest, reduce the activity. As I showed you, you can show them appropriate exercises for the knee, for the shoulder, the ankle, etc. Now, medications, NSAIDs, truly NSAIDs is one of the mainstay of medications for orthopedic conditions, for joint conditions. And we'll come to that. And sometimes, in fact, commonly for conditions like acute sprain, acute injuries, I like to ask them to take the NSAIDs for at least 5 days regularly, regardless of whether there's pain or not. Take for 5 days regularly and then followed by as needed. And because these 5 days will give a constant anti-inflammatory effect to the injury. So many patients tell me that that they say, oh, if for example, I have no pain tomorrow, do I still take the medications? And then I tell them, yes, based on your condition, I think you have an ankle sprain. I think it's better to take it 5 days regularly, and then followed by PRN. Now, as you have mentioned, NSAIDs is one of the mainstay of treatment for joint and orthopedic conditions. And now we'll look at some data on Celebrex, naproxen, the others. Now, before I start, I just want to qualify that over my years of practice, I have naturally come to use Celebrex more. It's just through my own practice, because I do find that it has less side effects, especially on the stomach, in patients with high blood pressure or patients with ischemic heart disease. I am wary of giving alcoxia, and certainly we know that celecoxib is a COX-2 inhibitor, and so it's a gastroprotective function, and this is better than COX-1 medications like diclofenac, naproxen. For myself too, I usually don't like to give too high a dose, so I find that Celebrex has a good dosage where you can come in. That I feel alcoxia is a little bit high. Maybe, for example, Ponstan may not be strong enough. So I think Celebrex is a good starting point. So we look at some studies conducted on Celebrex, and this one shows that for knee osteoarthritis, Celebrex 200 milligrams per day and naproxen 500 milligrams twice a day significantly reduce pain over 12 weeks. So we certainly, it works. Is as good or even better than other NSAIDs that we know, and that's the main point of this study. These two lines represent Celebrex and naproxen. This line represents a placebo, where there's not much improvement. Same, Celebrex 200 milligrams per day and diclofenac 50 milligrams 3 times a day, both significantly reduce pain. So again, Celebrex, you can give it as a once a day or twice a day kind of dosing, and it has pretty much same efficacy as if you give diclofenac 3 times a day. So that's a lot more convenient for patients. Now, this study shows patients who had already had treatment with naproxen and ibuprofen, and they did not seem to respond or tolerate, meaning that they maybe developed side effects. And so the study put patients on Celebrex, and there is an improvement in pain. Now this one is interesting to me. For knee or hip osteoarthritis, the researchers found that there were fewer osteoarthritis flares with Celebrex 200 milligrams a day continuously versus intermittent use during 22 weeks. So that would be roughly about 5 months thereabouts. Now, I presume this study may have been done in patients with quite at least a moderate to severe grade of osteoarthritis. So for me, just to share a little bit about my own practice, yes, I do give NSAIDs for osteoarthritis. Again, certainly I may ask them to take it, for example, for the first 1 week or 2 weeks regularly, and then usually thereafter I leave it PRN for them. For me, I don't like to give patients too much medication, so Celebrex is probably one of the best out there that we can choose to give. Now we look at side effects, a few slides on side effects. Celebrex 200 milligrams twice a day causes significantly fewer GI effects than diclofenac plus PPI. So this PPI is omeprazole. So if you were to give diclofenac and omeprazole together, there may still be a little bit more gastric side effects as compared to if you give Celebrex alone. So yes, for me, I give Celebrex on its own. I don't usually add PPI. Looking at cardiovascular side effects, Celebrex 200 to 400 milligrams per day showed no increase in cardiovascular events versus NSAIDs over 34 months. And this is something that is definitely important because as we know, some other COX-2 inhibitors had actually had documented relationship with increased cardiovascular side effects. Again, on GI side effects, Celebrex is not significantly different from placebo on any symptomatic upper GI event. So if you were to give them Celebrex versus if you were to give them sugar pill, placebo, it's about the same in terms of side effects, but certainly not efficacy. Now coming to this slide, the precision trial. This slide was this study was published in New England Journal of Medicine. The most recent trial with Celebrex showed no significant difference in cardiovascular side effects versus naproxen and ibuprofen. Now, amongst the traditional NSAIDs, I feel that naproxen probably has one of the more safer safety profiles, and I think it's encouraging that Celebrex has been shown to have similar safety profile with naproxen, and which is basically a low risk of GI or cardiovascular side effects. And so we've come to this slide, and this is assuming you have seen the patient through tele, you have treated them with medications, and when does it come to a point where you feel that you may need to refer to a specialist? Certainly, certainly is highly variable, and of course it's dependent on each doctor's individual practice. Of course, a few general reasons why you may want to refer: if the patient feels no improvement, if you suspect a pathological condition, and the two most worrying, as I've mentioned right at the start, is a septic condition or a tumor-related condition. Now, if you suspect a condition which needs further evaluation or treatment, for example, a fracture, ACL tear, severe ankle sprain, rotator cuff tear, bad osteoarthritis, these are conditions which may require intervention. And so if you do think that, for example, if you do think there's a fracture, then certainly most primary care doctors wouldn't wait. They would refer straight away. So again, it comes down to a judgment call when you will want to refer. Just a couple of closing points. I think that when patients come to see the specialist, for a specialist workflow, I think it would still likely be like a normal workflow: a physical consult, then X-rays, MRI, and then we review, and then we discuss treatment and do treatment. Because I think that if, for example, the primary care doctor has had a tele with the patient and they come to see a specialist, certainly I don't think we'll be able to reassess through the same medium, which is tele. And certainly by the time patients come, many of them will need X-rays and MRI to diagnose. But just one idea that I've had for a possible new workflow, and that is for joint tele assessment by a GP and specialist for conditions where you may feel that it's not so serious that you feel should be comfortably treated by a tele, but where you felt that you may want the specialist to give a bit of assurance to the patient, I think it's possible that this can be done. And so both doctors can assess the patient at the same time and coordinate care. And I think patients will feel quite reassured in this way. Just an idea. And so thank you everyone for listening. I've come to the end of my talk. And I hope all of you have learned something now. And I'll pass it back to Dr. Gayatri for the Q&A session.